ventricular hypertrophy is to examine changes in the QRS amplitude in the precordial leads. Here is the heart in axial cross-section again, and here is our AV node with the His bundle, and this time with the right and left bundles. Let's examine the typical QRS complex in V1 and V6 in normal hearts, RVH, and LVH. In normal hearts, the initial phase of ventricular depolarization is a left to right wave of depolarization across the intraventricular septum. This results in an initial upwards deflection in V1 and an initial downward deflection in V6. This initial downward deflection is sometimes referred to as a physiologic septal Q wave as an acknowledgement to its origin. In reality, the source of this deflection may be more complicated than this, but this simplification is sufficient for understanding EKGs. After that initial deflection, right and left ventricular depolarization occurs nearly simultaneously. As the muscle mass of the left ventricle is normally much greater than that of the right, the net vector of the main phase of ventricular depolarization is directed away from V1 and towards V6. Thus, V1 registers a deep negative deflection, and V6 registers a tall positive deflection. Hypertrophy of the right ventricle changes the relative balance between the two main depolarization vectors. Now the net direction of depolarization is towards V1 and away from V6. Therefore, V1 records a tall R wave, while V6 records a deep S wave. In LVH, the vector towards V6 is of even greater amplitude. As a consequence, the S wave in V1 is deeper and broader, and often lacks the initial upwards deflection, and the R wave in V6 is taller and broader, and often lacks the initial physiologic Q wave. One can summarize these findings by saying that in the precordial leads, RVH causes the QRS complex directionality to be the inverse of normal, while LVH causes the QRS amplitude to be more pronounced but in a normal direction. As leads 1 and AVL run in the same general direction as V6, often the same findings we see in V6 here in both RVH and LVH will be present in those limb leads as well. You may have noticed that the ST segment and T wave for some of these QRS complexes appear a little unusual, which brings us to the next topic. Summarize the EKG findings of ventricular hypertrophy. First, unusually tall R waves plus or minus secondary repolarization abnormalities are found in V1 and V2 in RVH, and in 1 AVL, V5, and V6 in LVH. An unusually deep S wave is seen in 1 AVL, V5, and V6 in RVH, while it is seen in V1 and V2 in LVH. RVH can deviate the QRS axis rightward a positive 90. LVH can deviate it leftward of negative 30. Although I haven't previously mentioned this, because right and left ventricular hypertrophy often go along with right and left-sided heart failure respectively, RVH is also associated with findings of right atrial enlargement, while LVH is also associated with findings of left atrial enlargement. Conduction abnormalities, which are covered in another lecture, can also be present and may be either complete or incomplete. Finally, RVH is frequently associated with poor R-wave progression or even reverse R-wave progression, while LVH is associated with delayed intrinsicoid deflection. Findings can be present in patients with true LVH. Romhilt and Estes developed a point system. As you can see, various features on the EKG are given either 1, 2, or 3 points. If the total score is 5 or more, they suggest that LVH was essentially definite, while if the score is 4, LVH was probable. Finally, there are some additional factors affecting the diagnosis of LVH by EKG. First, there are factors that increase the sensitivity of the EKG but decrease the specificity. That is, factors which increase QRS voltage irrespective of the presence or absence of LVH. These include younger age and male gender. The effect of age is significant enough that many cardiologists won't attempt to diagnose LVH in patients under 40 years unless the EKG findings are profoundly abnormal. Then there are factors which decrease sensitivity but increase specificity, that is, factors which decrease QRS voltage irrespective of LVH. These are older age and female gender, as well as obesity, COPD, and pericardial and pleural effusions. At this point, I'm going to This is left ventricular hypertrophy. There are a whole collection of features to note here. First, there are tall R waves in leads 1, AVL, V5, and V6, with secondary repolarization abnormalities. There is a relatively prominent S wave in V1. The QRS axis is leftward deviated, probably around negative 45 degrees. And finally, and this may be easy to miss, if we look very closely at the QRS complex in the lateral precordial leads, and we look at the intrinsicoid deflection, that is the duration of time from onset of the QRS to the peak of the R wave, we see that it is somewhere between 50 and 60 milliseconds, which is prolonged. This is right ventricular hypertrophy. We see the tall R waves in V1 and V2, with a mild T wave inversion in V1. In 1 and AVL, we see relatively prominent S waves. Finally, there is right axis deviation. The axis in this case is probably about positive 120. There's more than one diagnosis here, as we have both left atrial enlargement and left ventricular hypertrophy. Zooming in on V1, we see that there is a very prominent negative terminal component to the P wave, which encloses an area greater than one small box. Although we don't see the prominent secondary repolarization abnormalities that were present in the previous example of LVH, the QRS voltages are still elevated. For example, if we look at AVL and V3, we can see that the patient satisfies the Cornell criteria for LVH irrespective of whether the patient is a man or woman. And if we look at V5, we see that the R wave is greater than 26 millimeters, one of the Sokolow-Golian criteria. I won't go through it in detail, but this patient also clearly meets criteria using the Romhilt-Estes scoring system.
Hope you liked our video. Share this information with your loved ones. And don't forget to subscribe to our channel. Thank you.